and the GDMCC, what we knew 15 to 20 years ago, it's truly remarkable what we know about primary ciliary dyskinesia in 20 years. And it's a lot with the consortium. So the ability to bring sites together from a North American standpoint and recruit patients into natural history studies, which often aren't funded by the NIH, quite frankly, I think has been very helpful. The gene discovery has been remarkable.
Yeah.
I mean, there was one gene in 1999. So the gene discovery has been remarkable. The increased understanding of diagnostics, the increased understanding of the phenotype, so that we actually think about testing for the disease. I mean, I'm telling you, 20 years ago, pulmonologists were not thinking about this regularly. Now they're thinking about it regularly. I'm an associate editor for a journal, and there are papers on PCD coming through all the time. That was not happening before. The understanding that disease begins early, and that these patients have evidence of quite early bronchiectasis, and that there's genotype-phenotype associations. We didn't know any of that before. We didn't understand the overlap with some of these other ciliopathies. And we also really, from a mechanistic standpoint, I think we understand the underlying disease a little bit better. Tom can add some more.
Yeah, I mean, we now know the various genes that are, so as I mentioned before, it's probably between 600 and 1,000 different genes that encode proteins that are necessary for cilia assembly, structure, and function. We're now understanding what these individual proteins are doing that allows the cilia to form or allows the cilia to move appropriately. And so it's now potentially providing us with therapeutic targets that if you can correct or bypass the defect, can you then correct mucociliary clearance and then prevent the chronic infections in the lungs and the sinuses and the ears that people have with this disease? I think the other aspect of this, and again, Stephanie is associated, I've written more than a few chapters on primary ciliary dyskinesia. And I want to retract every chapter that I wrote more than 10 years ago because it was too vague. It did not say nearly enough about this disease, and it was not I don't think it was particularly helpful. So it's more than just whether or not a child has a daily cough or has a cough. It's more the cough has to begin in early infancy. It's wet all the time. It's there every day. There's no seasonal pattern. And as Stephanie said earlier, antibiotics may reduce it, but it doesn't resolve it. And the same thing so you ask that very granular question along with other very specific questions to families, you get a much better, you can really hone in on the individuals who are most likely to have a classic form of primary ciliary dyskinesia. So so as Stephanie was saying, I think everything has changed in this disease. We're using genetics more than we're using ciliary ultrastructure as a diagnostic tool, although we still use the latter at times. We have other tools that, like I mentioned before, that we can screen patients that will help us feel more comfortable to pursue these rather complex and fairly expensive tests. We know which ones we should be looking at based on the clinical features of the disease and what we should be asking to determine the relative likelihood that someone does have primary ciliary dyskinesia versus those that do not. And then the other aspect of this, and again, I kind of started with this, so I'm going to circle back, is that because we understand the genetics and we understand what these individual proteins are doing in an airway cell, it now gives us targets for either gene therapy or RNA therapy or potentially more small molecule therapy to try to correct the defect at the root. And that's something that we don't have yet.
Yeah, I agree. It's the one thing I would say is just highlighting what Tom said, classic phenotype. I do think we're now seeing more mild phenotypes.
Yeah.
That classic presentation of wet cough from birth, runny nose from birth, that is a classic presentation. But we are now understanding there's more mild phenotypes going along. I mean, this is why, frankly, I think I always tell fellows, this is an awesome field to go into and study. It's like where cystic fibrosis was like 30 years ago.
Yeah.
I mean, because cystic fibrosis now has just advanced so much. It's incredible. It's like a medical miracle what we've seen in CF. I mean, we don't even admit these kids hardly anymore. It's truly remarkable. But PCD is still in a lot of discovery phase. And so I think it's a really great disease to try to study and understand.
I mean, there's a lot of kids that are out there that are, so let's go back to the recurrent ear infections. There's a lot of kids who show up in otolaryngologist's office who have repeated episodes of ear infections, and they have tympanostomy tubes. And a small subset of those may have primary ciliary dyskinesia. And if you ask the right questions, you may find them. But I'm with Stephanie on this one. There are kinder, gentler forms of ciliopathies. I'm not going to call it primary ciliary dyskinesia because I think that's sort of an anchor point. But forms of ciliopathies that result in disease that we haven't quite recognized that this defect in the cilia, which may be relatively subtle, is causing this. So, for instance, you have kids with chronic ear disease. You have kids who have chronic sinusitis or chronic rhinosinusitis, but do not have allergies. We have individuals who have chronic cough, almost like a chronic bronchitis, but they don't fulfill any of the criteria for the causes for chronic bronchitis in a child or even as an adult. I suspect we're going to find that there are more than a few individuals who have subfertility, men and women, where we're going to discover that it's because you got a funky cilia or a funky sperm flagellum. But it doesn't meet criteria for primary ciliary dyskinesia. So we are very much defining the tip of the iceberg. And as we dive under the water, if I may continue the analogy, we're finding that there's a lot more than we knew.
Yeah, and the consortium's been incredibly helpful. I mean, I can't highlight enough how great it's been. It's been really what has catalyzed what we've done. So it's only 4 cycles, so we rotate off. We're like we're rotating off this cycle. Which they need to. There's 7,000 rare diseases. They need to fund other rare diseases.
That's right. We're dead men walking.
The other thing the consortium has done is it's given us opportunity to train the next generation who is going to care for these patients and take the research to the next level. And that's been a huge emphasis in the consortium, as well as throughout the rare disease network. So I really want to emphasize the importance of that because we have to have the young people come along.